Okay, hi, welcome to Med Medicine with Miss P. I'm gonna do this one more time. My phone shut off twice because the memory's full. And yes, I know, Emily, I need a camera, but I can't do that right now. So this is the best it gets. Also, it is storming outside, so there's a good chance the power's gonna shut off. And if it does, I'm gonna get in fetal position on the floor here and just cry because I don't have time for this. I'm gonna do this one last time, then I'm gonna cry. And if this doesn't fly, we're just skipping this week and we'll hit next week. Oh God, I just heard that can't be good. Anyway, okay, so I wanted to start with assessment this week, and obviously that's not going to happen. So I realized I would be kind of jumping ahead and missing a big point, which is report. Kind of how to survive clinicals, basically. So first term students, focus, and new employees, new nurses going out there for your first job. Listen closely. Number one, be on time. Okay, be on time. Just be there. You gotta be there on time, and you gotta show up. It's really important that you get there before we start tapping our toe and looking for you, because that's not a good sign. That is not good job ethics there. That makes us a little concerned. You got to be there. You got to show up. We know stuff happens. We know people get sick. We know that there's a highway shutdown. There's a car accident. There's rerouting. We understand all of that. So try to make those as limited as possible, which means those days that you can get there on time, make sure you do. We know you oversleep. We know that you have to drop the kids off at 6, and clinical's an hour away, and you're barely going to make it by 7, or that sort of thing. We understand that, but still do the best you can to get there on time and show up. Don't think, well, I have so many clinical hours I can miss, so I'll miss this one. You really need to be there for clinical. It is super important. You don't get nearly as much as you need, I promise. You want that experience. The more you do it, the less scary it is, the more you get better at it, and the better you do. So you really want that experience, I promise. I know it doesn't seem like it. Also, park where we tell you to park. I'm just going to leave it there. Employee, clinical, student, whatever, park where we tell you to park. Quit sneaking out of your car on the front row. We know you're not supposed to be there, and you're just going to get sent home, or it's going to be a worker ethics issue. Just park where you're supposed to park. Put your cell phones away. Come on, that's a gimme. That's the hardest thing that I have to kick you out for. Just, I understand. I don't even care if you have it on you. I know I'm not supposed to, but as long as it's on silent. I know you got kids, you got family members that need to get a hold of you if there's an emergency, and they're not going to be able to hunt you down in a huge facility where they have no idea who you are. I get that, but you can't have it out. You certainly can't have it out in a patient's room showing them pictures of yourself shirtless. I will never forget that student. God bless him. So make sure you don't have your cell phone on. Dress code, dress appropriately. Follow the dress code of your school. Follow the dress code of your work. Don't be showing things that shouldn't be showing. Don't have tattoos, purple hair, whatever you're not allowed to have. Cover them up, or don't have them. Whatever you need to do to comply, it's important that you do that. Jewelry, I promise you will wish that you just had your wedding band on, or that silicone band or whatever, because the one time you cut somebody open, that crepey steroid skin, you cut them open with your ring, you're gonna feel really, really bad, and then you won't ever do that again. You know how to stop that? Don't do it in the first place. Leave those pretty rings at home and just wear that one wedding band or something if you give patient care, that you're not gonna risk that, because it happens and it could be avoided, so don't do that. And also, brush your hair. Okay, those of you who know who I'm talking to, right, babe? Brush your hair. Wash it too. That's always helpful, so we don't see the grease sliding in between the separated rows of hair when you just barely threw it up on your way to clinical. Brush your hair. Okay, there's the messy bun that's like kind of cute and in style. Then there's an I don't care what I look like bun. Choose wisely. Okay, so once you get there and you're all set and you finish pre-conference and you're heading to the floor, couple little words of wisdom. You have to do things that, whether someone's watching or not, you need to do these for patient safety. You have to gel in and gel out, foam in and foam out. You have to answer all of the call lights. You don't walk by a call light. That's a patient in need. Doesn't mean you have to drop what you're doing to help them, but at least recognize it and find out what they need, and see if you can't quickly find someone to help them. And pass the trays. When the trays come up, they announce them on some of these floors where we do our clinicals, because it's important that everybody gets a warm meal. And these 3 poor techs trying to pass 40 trays It's that 40th person is not going to get the warmest meal. So work with them, help us out, and pass those trays. And that's kind of the given, how you can survive clinical. So first term, carry that all the way to third term. Don't get lazy, don't get stupid. We're watching, we're paying attention, and do the right thing. And even as a nurse on the floor, do the right thing. Help these trays pass if you're not doing something emergent. So before you get report, sometimes I'll say, go introduce, as a student, I'll say, go introduce yourself to the patient. And if they're like, get out of here, I don't want a student, come back and let me know before we even waste time with report and that sort of thing. So it's okay to introduce yourself to that patient, but I wouldn't do anything further than that. Maybe get some vitals, which you now know how to do, but don't do anything further than that until you really know what's going on with that patient. And that comes from report. It's not, this is what he's admitted with. He's a 76-year-old male, and this is what he's got, the end. That's not report, y'all. You need to know exactly what's going on. If this is a nursing home or a skilled facility, long-term care, that sort of thing, you need to know what the last hospital stay was. Were they in for pneumonia a couple weeks ago and you need to make sure it doesn't reoccur and focus on that? Or was their last hospital stay 6 years ago and they've been good to go since, so you know they're pretty stable? You want to know what that is and then what the results of that was. How severe was it? Were they intubated? Did they go home with IV antibiotics? Did they have a PICC line here at this facility? That sort of thing. You really want to ask those questions, look in the chart, and figure it out so you know what they've been through. So if they have a little bit of a cough and they get scared and they get worried, you're not going to say like, you're fine. You would realize why they're worried about it if they think that they're going to relapse into pneumonia, even if it was 6 months ago or 2 weeks ago. So get a good report. Report means everything you can possibly find out about that patient. And I'll even joke with my students and say, like, you need to know their favorite color and their childhood dog's name. Know what's going on with this patient. And if your nursing instructor or whoever's giving you report, the nurse that's taking care of that patient, or sometimes even the tech, we kind of have to get report from the tech. If they don't tell you, that's not like, oh, well, she didn't say. I get that all the time. Well, she didn't tell me. Ask questions, know what's going on. So when they say like, oh, he was admitted with chest pain. Okay, chest pain's not a medical diagnosis. Stop doing that. Stop telling me that. It's not a medical diagnosis. No one says like, the doctor called, mama's got the chest pain. I don't know, she's diagnosed with a chest pain. I don't know what to do with it. It's a symptom of a cause. Something is causing the chest pain. Probably, I don't know, cardiac death, cardiac tissue death, lack of blood flow to a portion of the myocardium, right? So isn't that a little more important than the symptom of her telling you she has it, right? Or describing the pain? You need to know what's going on with that heart. So when you read the H&P, you'll see that it is trying to kind of rule out if it's radiating pain to the jaw or the shoulder or the back. Is it crushing? Is it burning, aching, dull, sharp? And you get all that information. So he's trying to say, is it epigastric or is it cardiac? And depending on those two, we're going to treat it accordingly. So they're going to get a series of cardiac enzymes. They're going to do a 12 lead, maybe even an echo, depending on how long they've been there. They may be set up for a cardiac cath, a chest x-ray. All of those things you need to know the results of, which means you need to know what's high, what's low, and what do those numbers mean. And we'll talk about that a little bit later. But at least get that information so you know what you're looking for. If the patient was admitted with pneumonia, well, then you're going to want to know what the ABGs were. What was the SAT on intake? How many liters of oxygen do they require just to, stay satting at a reasonable level? You're going to want to see what the chest x-ray says. Do they have a pleural effusion? Is this a fluid overload issue? Is it strictly pulmonary? Get into that, and you have to ask those questions. And even if you don't know what to ask, don't be afraid to say, well, what kind of tests were run? What kind of things might I need to know because of this, patient's diagnosis? Whether you're asking that nurse, who hopefully is very kind and very helpful to you, letting you have all that information, or we can look in the, chart together if it's, your instructor's there with you. It's really important that you recognize that. And I know a lot of test results you don't understand yet, but we're going to get there. We're going to go into all those test results. If you stay with me, share with a friend, tell somebody, because we're averaging about 100 views, which I think is pretty good, but I feel like we could reach more people. So share, tell others, do what you can to to get people watching. If you feel like the content is worth it, I'm going to try to keep them kind of short and just little tips and tricks. We're not, going deep into it. I just want to give you a couple things. Now, when we get into meds and disease process and test results and that sort of thing, we'll get a little deeper, but real basic, kind of just how to survive clinical. These are the things you need to look for. More than anything, I look for initiative. Like I said before, I want you to want to learn. If you're there because you lost a bet or your mom's going to kick you out of the house unless you go to school, you may not be my best student. But if you want to learn, I will teach you everything you'll need to learn, or you'll need to know, anything I can. And I'm learning every day also. I still ask questions I still want to know. I'm still always trying to get to the bottom of it. So if you can't get to the H&P, remember that H&P is kind of like, the first paragraph is the train wreck they came in on, and the last paragraph is what we're going to do to make them better. Now, what he means by his plan or her plan is really your plan. He's going to tell you what to do, and you're going to do all of these things. So whatever the plan is to try to get that patient better, you're the one that's going to be filling out or completing all those interventions. So you need to know what the plan is and how we're going to get them better and what they find. The other issue to that, like always, is talking to the patient. Half of that is going to come from report, and the other half, once you go in to start your assessment and get your vitals and that sort of thing, talking to the patient also and asking them questions. Some of that information may not have been communicated correctly to the caregiver or the provider, so that H&P may not be right on it. And I know students and I have seen it together. It'll say like, history of a left total knee replacement, and then somewhere in the history it'll say right knee osteoarthritis with a total status post total knee replacement. And you're like, which knee was that? And then you have to go check the patient for the big long scar on, across their kneecap. So getting that information from the patient will help also. And what I really found over the years is whatever they're admitted with or whatever they're complaining about sometimes isn't nearly as important as what's really going on with that patient. And this is the example I've used repeatedly because I've seen it so often. 76-year-old female is in the hospital with chest pain. CEs are negative, chest x-ray is negative. The, her complaints are dull, crushing, pain in her chest. It comes and goes. Nitro does or doesn't help it. The echo looks normal. They can't figure it out, right? Talk to her for 5 minutes and find out her husband of 46 years passed away 2 months ago. And once all the hubbub is over and the funeral is finished and the family's kind of dwindled down, gone back to where they are, now she's left home alone with a broken heart. So talk to these patients and find out what's going on and see how you can help them. It really matters. So another aspect of their history is their med list and allergy list. If they're allergic to 3 different antispasmodic or seizure medications, they have a history of seizures. What else is that medication used for? If they're allergic to 10 different narcotics, then they've had 10 different narcotics. They've got chronic pain. If they're allergic to ACE inhibitors because of the cough or that sort of thing, well, then you know that they're probably a cardiovascular patient. So it doesn't take rocket science. When they're allergic to like 30 different antibiotics, they've had multiple infections. It may be a urology patient, right? So those are the things you really want to look at and see. And when they have 30 different allergies, you also know that directly corresponds to their IQ dropping it at least 60, 70 points. So those are the things that you will learn about that patient as you go. Report is super important. And if you can't get enough from the nurse and she's like, oh, I don't know, I'll say like, well, when was that IV started? Oh, I don't know. Or check the chart, or, I'll have to look. When's that dressing due to be changed? All of those things. That is all important to get in report. Who's their hospitalist? Who's the first person you were going to call, right? As a nurse, not so much as a student, but as a nurse, you need to know who you're going to contact, the last set of vitals, what the last tele, if they're on telemetry, what the last tele reading was, what are we looking for? What's their history there? And then what's their pain toleration? Those are all things you really need to know. If they're diabetic, ACNHS, what was the last A1C, as well as AccuCheck. It's a lot, I know, and it can be overwhelming, but all of those things you need to know to give good care. It's really important that you get all that down pat. And then once you, introduce yourself to your patient, get your vitals, then I always say I kind of tidy the room a little bit. So if you're doing bedside report, which we should all be doing, when you do that bedside report and you're kind of looking around and there's a stack of, unused towels and linen and stuff in there, which now can't leave the room, or, the hamper's overflowing or the garbages or something, you kind of want to let that previous nurse know that she needs to, take care of that before you hop on shift there. That shouldn't be left for you or your problem. So, don't be afraid to say so, and make sure that patient has everything they need and that room looks good when their family comes to visit and that sort of thing. When papers on the floor, there's always an alcohol prep pad on the floor. I don't know how it gets there, but there's always an alcohol prep pad and a cap from the IV or something. Those are the things that are always on the floor. Pick them up. It takes 2 minutes. Foam in, foam out. Wear gloves. Don't care. But clean the sink area. Whatever crap they've got. Empty the urinal, for the love of God. Please stop leaving the urinal full by the bed. That is just, how are they going to pee in it again if they need it? By dumping it on themselves as they try to use it again? Clean all that stuff up. Get a nice clean slate to start your day. And then just remember safety, super important. Watch those IV lines. I hate when they're touching the floor. What's on the floor? Is it what lives on the floor? Nice, clean, Clorox-filled genes or germs that are not going to, further this patient's stay. So get the IV line off the floor. Any cords or anything you can get out of the way or loop up or kind of make sure that their path to the bathroom, if they're getting up and allowed to go to the bathroom, is free and clear. Make sure you've got that out of the way. Make sure that if you go into a patient's room and they ask you to take them to the bathroom, that they are capable of walking, that you know what to expect. And if not, say, give me 1 minute, I'll be right back. I just want to make sure you check with their nurse or their tech and see what's going on when you're answering those call lights, or if it's your patient yourself, make sure you know all those things. And especially that O2, when it's on the floor, not even on the patient. Yeah, clean it off or get a new one, put it back on them, make sure if they're supposed to have O2 continuously, they do. It's really important you do that. And that's about it. I'm big on reports. You really want all of that information, that history, it matters, and learn how to write it correctly also. So if they've got osteoporosis,